All right, well, welcome everyone. Today we have a bit of a special treat for Joint School Live in that we are doing a bit of a departure from joint replacements, but we're not traveling too far. We will be looking at hip arthroscopy or keyhole surgery of the hip. And to cover this topic, we have none other than Professor Siôn Glyn-Jones from Oxford, who is an absolute expert on the topic. And I look forward to digging into this. Before we begin, Prof, is there anything you'd like to say about who you are and what you're bringing to this virtual table?
So thanks for the kind introduction anyway, Axel. But well, just to give you, just summary, I sort of work at the Untitled Orthopaedic Surgery at Oxford, which is a what we call a tertiary referral centre, which is a specialist hospital doing nothing but orthopaedics. And my job there is to run the young adult and sports hip unit, where we're looking into doing joint replacements in younger patients, that's hip replacements, but also joint preserving procedures such as hip arthroscopy and sometimes osteotomies around the hip. That's various other operations. Now, in addition to that, I run a research group looking at the University of Oxford, looking at hip arthritis, how we cure it, how we prevent it, and understanding why it happens. And so we've done lots of work into many of the conditions that we will be talking about today related, which we treat with hip arthroscopy.
Yeah, well, fantastic. Thank you so much again for joining us. And I must say, I think we've done about 80 odd videos now on the channel, but this is the first time that we're speaking with a surgeon who's live and direct in theatres. So absolutely extra points for authenticity.
Yeah, well, yeah, thank you. You caught me at the end of an operating list, so hopefully I don't appear too tired.
Excellent. Well, let's get cracking then, and I guess begin with a sort of very big and wide question. What is hip arthroscopy?
Well, hip arthroscopy is keyhole surgery of the hip. So many people will be familiar with keyhole surgery of other joints, particularly the knee. It's where you will put small skin incisions, typically around 5 millimeters long, on the surface of the patient, and then you use long instruments, telescopic instruments, to look into the joint, and then other instruments to manipulate or repair things within the joint. And so hip arthroscopy is that principle, but applied to the biggest and deepest joint in the body. So unlike other joints, it comes with its own special challenges. And so I suppose it's probably one of the reasons why other joints were developed. People developed hip arthroscopy for other joints before the hip itself. But hip arthroscopy has been around now in very primitive form for 30 odd years. But in its more advanced form, we've been pioneering that really to some extent in the UK, but also other places around the world. Since about the late 2000s, certainly late 90s, a fair bit was being done as well. So it's a relatively new procedure as surgical procedures go, but it has been, we've spent the past 10 years evaluating it, making sure what we're doing makes people better and is safe.
Yeah, okay. And when you say the more advanced form of hip arthroscopy, what does that entail? What does that mean?
Well, to begin with, and from the 1980s onwards, we've been doing it in Oxford. And to begin with, people were just accessing the joint to see what was going wrong. So that's called a diagnostic procedure. Thereafter, people would do minor things to try and trim bits of cartilage where there was a tear, or fish bits of floating tissue out to the joint where it's causing the joint to jam. And then more recently, we've been able to do much more extensive procedures that we would normally have done through open incisions, very large incisions, possibly where you have to dislocate the hip joint or make very large incisions on the side of the leg in order to access them. We've been able to do those sort of operations now through keyholes, so repairing structures like the labrum, reshaping the hip where people are born or develop shape problems, deformities of the hip, and we can do a variety of other things, even graft tissue, and we've done studies recently looking at stem cells and hip arthritis as well.
Okay, interesting. And I guess so there, the link to hip arthritis is one that has popped up among the questions that have been sent in, where people who are awaiting a hip arthroscopy or who have been told that they might need one are wondering about the relationship between hip arthroscopy as a procedure and then potentially either developing arthritis, or perhaps even hip arthroscopy as a potential treatment for arthritis, and the link between that?
Yeah, so I mean, the best way to look at that, and the way the treatments have changed, is to look at the conditions that we've been able to treat. So in the early days of hip arthroscopy, we recognised conditions that were due to trauma, such as a labral tear, or bits of cartilage that got knocked off during an injury playing rugby, for example, or whatever, running or something. In addition to that, we subsequently discovered that there are conditions in the hip that are the main drivers of osteoarthritis. So a condition known as femoral acetabular impingement, very long word, but it's abbreviated to FAI, is now been recognised from work that we pioneered in Oxford mainly, and through a series of publications about 15, 20 years ago. We demonstrated that a mild deformity of the hip can give rise to osteoarthritis. It's a very common deformity. About 1 in 4 people have it, and many of those people will go on in later life to develop osteoarthritis and need a hip replacement. So we now have the ability to correct the shape of the hip early on if we catch it soon enough, and go on to hopefully treat the symptoms that are related to these conditions, but also we believe, and there's some emerging evidence now showing that we may be able to modify the progression of arthritis in some patients.
Okay, well, so I think that's, without digging into too much detail, because clearly there's quite a few different indications, quite a few different applications of this surgical approach. What would you say is the most common reason for having a hip arthroscopy currently?
The most common reason is for a labral tear. So that is, the labrum is the lip of cartilage that goes around the socket of the hip, and it's quite a thick, long piece of cartilage that acts like a sort of seal around the socket of the hip joint. And that structure can tear, but it tears for a variety of reasons. And so I suppose the most common reason for having a hip arthroscopy is because of a labral tear. But the cause of the tear can be traumatic, but more commonly it's due to either the shape of the socket, so either a shallow socket known as hip dysplasia, or it's due to the condition that I've just mentioned, which is FAI, or femoral acetabular impingement. So quite often we're not treating this structure or repairing it on its own. We are trying to correct the other issues that may have caused the tear at the same time.
Okay, interesting. So that gives us a bit of a background to the procedure and the most common reasons for performing it. Now, I know from the questions and suggestions that have so kindly been sent in, and as ever, to anyone watching this, please do keep sending in your questions and suggestions and comments below. But so some people, when searching on the internet, you might find that in some parts of the world the procedure is not performed or it's not available, and they might also find, as you've mentioned, reference to it being a relatively newer procedure, even though there's now plenty of evidence to back it up. But what would you say to someone who comes with that sort of question?
Yeah, I mean there'll be centres like our own that have pioneered the operation over several decades, and so I suppose they are the early adopters of a procedure, or the people who innovate in that area. And there are a few centres around the world that would fall into that category, maybe 4 or 5.
Mm-hmm.
Then there'll be a group of surgeons that will take an interest thereafter in performing a procedure, and will go out and get trained to do that, and develop their own skill and their own interest in their own region. Mm-hmm. And some countries, because of the nature of where the procedure has been developed, have been ahead of the field. So the UK has been very much at the forefront of developing this procedure, testing it, evaluating it, and refining it, making it better. US has also taken a big role, but there are other countries around the world that have done the same. Now, there are also some countries that were late adopters of this technology, and as you mentioned, there are some countries do not do much of the procedure. And so if you look at Europe, for example, and you will find that some countries do far more of the procedure, whereas others do barely any of the procedure. And that's more of a reflection of what we call the sort of commissioning environment. So is that procedure funded in their version of the NHS or their insurance system? And the second reason that would drive whether you do it or not would be the expertise of the surgeons in that particular country. So as you mentioned, some countries have a very low level of hip arthroscopy, whereas others are much higher than the average. And so, but that's more to do with experience, and you'll see that through all surgical procedures. So even if you take hip replacement, for example, there is a huge international variability in hip replacement. It doesn't mean that, you know, patients aren't requiring it at the same rate everywhere, which they generally are.
Yeah. Interesting. So I guess we can expect the rates of hip arthroscopy to equalize across countries over time as this technology becomes more available.
Yeah, generally speaking, you know, what we've done with hip arthroscopy, which is a slight benefit to us developing it more recently, is that we've been able to evaluate it in a very structured manner. So Oxford in particular have taken a role in looking at new technologies and saying, well, should we be doing this? Does this work on patients? Does it make them better? And we don't want to be doing operations in particular which are risky in some circumstances. Albeit keyhole isn't as risky, for example, as an open operation, but you know, there's still an element of risk with any procedure, and we would always want to make sure that procedure provides benefit to the patient, whether it's short-term or a long-term benefit. Of course, with hip arthroscopy, we've conducted what we call randomized controlled trials, and there have been actually 2 conducted in the UK, which have both shown independently that the procedure works and is effective. And so we understand, we've taken a rather responsible attitude in the UK in particular in developing this procedure. And so we are now looking at the next stage of that, is does hip arthroscopy slow arthritis? Does it stop the need for a hip replacement? And those are the long-term questions we're looking at.
Right, interesting. Okay. Well, if we then move on to the procedure itself, and to those out there who've been in touch and who've sort of requested an interview on this topic, what should they expect of the procedure itself? How long does the procedure take? And so on. Can you talk us through the typical experience on the day of a hip arthroscopy?
So, I mean, a hip arthroscopy is normally done as a day case procedure. So you would do it as a come in the morning, go home in the afternoon procedure, unless you live very, very far away. Some surgeons do it as an overnight stay, but majority of patients would go home at the same day. It is done under a general anaesthetic in most cases. In Oxford, we use a combination of general and a local anaesthetic, and sometimes local blocks as a way of minimising pain after the surgery. It's not a particularly painful procedure, and so it's in that respect, it's not too challenging for the anaesthetist. In terms of some centres would also use what we call a spinal with hip arthroscopy. There's debate over whether that slows your recovery, but certainly that would, in most cases, stop you going home as a day case.
Right, okay.
After patients come in, they would normally, they would have a general anaesthetic. When they're asleep, they're put on what we call a hip arthroscopy table, and this is a modified operating table that allows us to position the hip in the right position. Now, when the body's asleep under anaesthetic, the muscles become lax, and so it's much easier to separate the joint surfaces. And so if you put a little bit of what we call traction on the limb, so if you pull on someone's leg, under anaesthetic, their joint will open in most cases quite easily. And so we typically put somewhere between 20 and 30 kilos of force through the leg, and that will allow the joint to slide open, and that allows us to get about 5 or 6 millimeter gap that we can get our instruments in to do the operation. And we check that with X-ray to make sure we're doing that. So we'd normally have an X-ray in theatre. We'd normally have this specialised table in theatre. And then obviously we have all the instruments that allow us to do the procedure, and there are many, many different types of devices that we can use.
And of course, one of the
the operation itself typically lasts about 45 minutes to an hour. It depends really on a variety of factors, the complexity of what you have to do, so that might make it a bit longer. The experience of the surgeon, so if the surgeon's doing less than 40 or 50 a year, you probably find that they're going to take longer to do it, and that's true for any procedure really. And hip arthroscopy is very experience dependent, so it takes quite a long time and a number of cases to get experienced enough to be be relatively quick at doing it, but also to be able to access things reliably. And so it's probably one of the more challenging keyhole procedures in that respect.
Okay, interesting. And so you mentioned about the positioning and applying a bit of force to be able to access the joint appropriately. From a sort of patient's point of view, what would be the typical number of keyhole ports required, so to speak? What kind of wounds or how many incisions are usually needed?
The incisions are on the front and the side of your thigh. Even though the hip joint is actually in the center of your groin, the incisions are remote to that. And the reason we do that is to avoid all the major nerves and blood vessels that run in front of the hip joint. And we're quite good at avoiding that. The risk of damaging one of those with a keyhole procedure would be way less than 1 in 1,000. And we looked at that in our, in several trials over many years. So we put the incisions on the outside, in the front of the hip joint, but quite, towards the side of your thigh. They are usually 2. Some people choose to use 3. And occasionally, if you need to work on other bits just outside the hip joint, you'll use 4 or even more. But majority would be 2 to 3 incisions, usually about 4 or 5 millimeters long. Okay,
and usually closed with an absorbable stitch, or?
I mean, so various surgeons differ. My own preference is to seal it because we use fluid to irrigate the joint when we're doing the operation. So we use a fluid under pressure to blow up the joint so we can see what we're doing. That's true for any arthroscopic or keyhole procedure. And so a lot of fluid can leak out through the incisions afterwards if you don't close it very tightly. So I would prefer what we call a subcuticular suture, which would allow the wound to be sealed quite tightly. Some surgeons put an interrupted suture, which works quite well, but can cause a little bit more fluid leakage after the operation.
Okay.
We have small absorbable sutures in the skin, which would be covered by 2 or 3 layers of dressing. And the dressings would typically be waterproof and allow you to shower them either the evening of surgery or the next morning.
Okay. Well, that's a nice way of moving us on into sort of showering and other activities that you can do soon after surgery. And of course, we're speaking in very general terms here. And to anyone watching this, ultimately, it's all about following the plan from your surgeon and your healthcare team. But generally speaking, what could one expect in those first few days after a hip arthroscopy? What is a kind of, again, casting a very general net for a typical course of recovery?
I mean, you would have the operation, you'd go to recovery, and then you'd go back to the ward, and that process, would be 3 hours in total for the whole thing normally. And once the patient is back on the ward, when their pain is under control, when they've had some food and a cup of tea, you'd then get them up. The physiotherapist would come up. Once we've explained the procedure to them, then they would get up and start you on crutches. So you'd normally spend anywhere between 1 day and 2 to 3 weeks on crutches. The average is probably about 10 days, but some people walk out of hospital without crutches. The majority walk out of hospital with crutches. And the crutches are there really just for pain management, so you're not having to put all your weight through the leg early on. Sometimes people have regenerative procedures designed to try and regrow cartilage in the hip, such as microfracture. In those people, we would typically take the weight off for 3, sometimes 4 weeks.
Right.
But the majority, 95% of people would be what we call full weight bearing straight after surgery. So in other words, if you don't need the crutches because it hurts, then you walk from whenever you want.
Okay.
The main difference between hip arthroscopy and other types of arthroscopy is the need to have a very rigorous physiotherapy protocol after the operation. Most keyhole procedures, you either rest and then ask the patient to just get it going as they feel they're able to. Mm-hmm. With hip arthroscopy, it depends on the surgeon, obviously, and every surgeon has a different protocol. Our own protocol in Oxford is certainly one that's quite structured, and we tend to get people going quite quickly because the hip is an interesting joint in that it's the repairs that we do internally are quite strong, but the joint itself has a propensity to scar up if it's not moved quite quickly after surgery. So we tend to focus a lot on what we call range of movement exercises the first 2 weeks. We then get a physio to see you 2 weeks after your operation, and then you would start doing gym work at that point. And so we then begin to ease people into things like exercise bikes, cross trainers, elliptical trainers in the first instance. And then building up to, you know, more intense gym activities, needing short runs by about the 6-week stage. Most of the recovery you would see, about 70–80% of the improvement in your pain and your function would be within the first 6 weeks. So there's quite a rapid recovery from that perspective. You then would go into a much slower phase to get the remaining 20 or 30% of recovery. And so you normally see it takes about 6–8 months in total to get to your very, very best after a hip arthroscopy. But by 6 weeks, you're usually pretty good. That's very variable. Some people have no pain at 6 weeks and are fully recovered. Others will take a lot longer to get better. But it really depends on the person, how long they've had pain, how severe the problem was, and any other issues they've got, such as, you know, painful joints nearby.
Right. Okay. Okay. And the role of the physiotherapy there, you raised as one that's of particular importance in the recovery from hip arthroscopy. And is that sort of directed physiotherapy for 6–8 months, maybe longer, or?
Well, not necessarily. A lot of it's patient driven. So you wouldn't want to. You don't necessarily need physiotherapy for 6 or 8 months. You certainly need it for the first 6 to 8 weeks. Yeah. Thereafter, you can tailor it to the patient's individual needs and what they get back to. So, you know, you'll have high level sport people that will come with their own physiotherapy team that will take care after 6 weeks, whereas others will never want to get back to more than occasional cycle rides, and they may not require any physio after 6 weeks. So, I mean, you know, it is very much a bespoke thing, but there is a core amount of exercises and a core speed at which you should be doing things after the operation.
Okay. Okay. Well, so I think so. So I guess as with any treatment pathway, really, it's about your bespoke plan from your surgeon. But in general terms, a key thing to remember with hip arthroscopy is that there's more of a role for physiotherapy than perhaps with other types of keyhole surgery one might come across or hear about.
There's a point to specialised physiotherapy as well. So it's useful to have people who are what we call sports therapists, or who are very experienced in treating people with hip problems. And so we tend to develop networks, surgeons who work in this area, of physiotherapists that work in and around our regions and even nationally, to try and get the best quality and the best understanding for our patients from the physiotherapy perspective. But it is very much a team role between the surgeon and the physiotherapist. And I always say to patients that, you know, we'll fix the problem in the hip, but there's another bit of treatment that needs to go on afterwards, which is the physiotherapy. So it's a joint effort, as it were.
Yeah, no pun intended. Excellent. Well, I think that's a fantastic overview of a bit of background to hip arthroscopy, why it's performed, some of the conditions and problems it hopes to treat, and about the recovery. Is there anything, just to sort of sign off, is there anything in particular that you would like to say as your top tips for anyone who's watching this, who's getting ready for a hip arthroscopy?
Well, I mean, you know, prehab is probably the thing to do. So if you're getting ready for a hip arthroscopy, do some exercise beforehand, because actually that will help your recovery hugely. So 6 weeks or so or even 3 or 4 weeks of exercises beforehand are essential. The other thing also is to keep an eye on, the various information resources on the internet. And, we've got our own, where you will see the new evidence published. There'll be social media links on some of them that will allow you to track what's new in this area, because it is quite a fast-moving field. There's a core operation set that we know works, but there are new procedures coming along all the time. For example, in Oxford, we've been doing a stem cell trial recently into hip arthroscopy and early arthritis, and there are a number of other type of trials going on around the world in that area.
Okay, well, so really watch this space, and by watch this space in particular, we will make sure there's a link to your website as well, where anyone watching this now, you'll be able to find out more information below. Super. Sure. Well, thank you so much, Prof, for joining us. I think this has been a wonderful introduction and overview to the interesting realm of hip arthroscopy, and good luck with the rest of your operating list.
Thank you very much.
Thank you so much for your time. And also thank you to everyone out there for sending in your questions. As ever, comment below, send in any questions and suggestions. Don't forget to subscribe and stay safe out there. Thank you, everyone.